Hello everybody, my name is Gianluca Tagariello. The title of my topic is The Management of Tridimensional Maxillary Atrophy with Non-Invasive and Fast Technique. I come from Taranto. Taranto is in the south of Puglia and is called the city of the two seas, the big sea and the small sea. This is the office in which I perform all the surgery that I'm going to show you. The anatomy of the maxillary sinus is described for the first time by Leonardo da Vinci in 1489 and then documented by Highmore in 1651. The maxillary sinus is the largest of the four paranasal sinus with a volume between 15 and 20 cubic centimeters. The shape is pyramidal and the superior wall is formed by a thin orbital wall. The posterior wall is related to the pterygomaxillary area of the skull. The middle wall is adjacent to the nasal fossa, and the lateral wall forms the posterior maxilla. The medial wall of the sinus coincides with the lateral wall of the nasal cavity. The wall is smooth and vertical, and in the superior zone is present the ostium of maxillary sinus, the Highmore ostium. Thanks to the ciliary movement, are drained into the nose. This wall, the lateral wall, is characterized by the support, the presence of the antral artery. And this is the antral artery. We can see it during surgery, but we can know its position using the cone beam. This is a very old classification of the parametrization of maxillary sinus. It was written by Misch. And you can see how it's old because they suggest to do a lateral one-stage approach in case we have less than 5 millimeter or between 5 and 8 millimeter of residual bone. I prefer to use a classification according to the presence of the absence of alveolar bone. And with this classification, I can decide what kind of device I have to use and which kind of approach I have to use for the bone regeneration. So I divide maxillary sinus parametrization without alveolar bone atrophy. In this case, I can decide to use a crestal or lateral access and a resorbable membrane. In the second case, we can have maxillary sinus parametrization with horizontal bone atrophy. So we can do crestal or lateral access, and we can use a resorbable membrane. Maxillary sinus parametrization with vertical bone atrophy. In this case, we can use crestal or lateral access and no resorbable membrane. A maxillary sinus parametrization with vertical and horizontal bone crestal atrophy, so we can use crestal or lateral access and no resorbable membrane. The crestal approach, the sinus lift with the crestal approach was described for the first time by Tatum, and then Summers created some modification in 1994. But the problem of this technique was the use of a hammer. Patients don't like the use of a hammer. The problem of this technique is the perforation of the membrane, 3.8% of the cases. And the patient many times had headache or vertigo. The membrane can be elevated between 2 and 4 millimeter. And we need to have minimum 5 millimeter of residual bone to use this kind of approach. And this is the last time which I use a hammer to elevate the membrane of the sinus. And you can see the bone inside the sinus. So I create a problem to this patient. I was lucky because there wasn't any kind of terrible consequence for the patient, but it's not the correct treatment for our patient. I would treat patient requiring a crestal lift procedure with an approach that will give them the less discomfort possible. And literature tells us that we can make crestal approach when we have a residual bone height of at least 5 millimeter, and we expect to have an increase between 3 or 5 millimeter. But I think that we can do more. So I start speaking about the crestal sinus lift with the use of crestal drill by Austin. And this is the sinus, this is the membrane that is intact before after the attachment and when we reach the membrane using the crystal drill. The most important characteristic of this drill are the blade. The blade don't cut the membrane. And during the use of drill, all the bone of the patient is collected between the blades, and we can use it to push with the graft, to mix with the graft and push it into the sinus. So here you can see the blade and bone between them. I can use this bone and mix it with the graft. So everything can push inside the sinus. But before this, we have to detach the membrane from the base of the sinus. And detaching is performed with use of saline solution using this kind of syringe. We push saline solution into the sinus, and the pressure of the saline solution is the same in every point of the membrane. When the membrane is detached from the bone, we can recall saline solution into the syringe. It comes inside, mixed with the blood of the patient. So we can understand that there isn't any tearing of the membrane, or otherwise we have saline solution that come from the nose of the patient. So we have the detachment of the membrane that is performed in the correct way. We can reach when we reach the desired height, we can insert our implant, and we can check every step with use of X-ray or with use of combine. In this case, we start from 3.7 millimeter of residual bone. We reach 13.7 millimeter with the use of bone, and after when we insert the implant, we reach 15.8 millimeter of the new regenerated bone. So it's very important use of combine to evaluate the situation of the patient. Through the combine, we can evaluate the anatomy of the maxillary sinus hiatus, the position of antral artery, if there's some septum, and the existence of physiologic process sizes and the actual residual bone quantity. In 2.6 area, looking this X-ray, we can safely place an implant about 7 or 8 millimeter length. But if we observe the combine of the patient, we can see that in that area we have only 4.4 millimeter of residual bone. And this meaning because the combine is the only exam that can make us understand how is the real quantity of residual bone of the patient. So we start our surgery with use of crystal drill, and we use the stop to control the force of the drill. And when we reach the membrane, we can start the attachment of it with use of saline solution. Then we can insert bone with using our carrier inside the membrane and push it with the use of a device and we put a stop on this device. When we reach the desired higher that we can control with use of X-ray, we can insert the implant. And after 6 months of healing, we have 11 millimeter of new bone. In area 1.6, we have only 2.7 millimeter of residual bone, and you can see the inclination of the sinus. And with the same technique, we can reach over 10 millimeter, 13.7 millimeter of bone inside the sinus. In only 5 minutes, we reach this higher, and then we can insert the implant. After the insertion of the implant, we arrive at 15.8 millimeter. So This is when we start during surgery and after the insertion of the implant. And we can check the change of the anatomy of our patient. In other case, we have only 2 millimeter of residual bone, 2.2 millimeter in area 2.6, and you can understand how could be difficult in elevation of the membrane if we use a lateral approach, because our sinus is near the root of 2.5 and 2.7. So we decide to perform our surgery using a CAS drill and the cascade. This is a cone-beam of the patient. And this is the membrane. You can see how it's intact after the use of a CAS drill. This is the residual bone of the patient. Now we start with the detachment of the membrane. So we push saline solution into the sinus. Then when we recall it and it comes into the syringe, mixed with the blood of the patient. Then we can insert bone and implant. After 6 months of healing, we can start with the prosthetic rehabilitation of the patient. And this is when we finish the rehabilitation of the patient. This is the pre-lifting membrane that is intact, and that is the post-lifting membrane after the use of saline solution. Sometimes during the surgery, we can see the movement of the membrane, like for the lateral approach. And you can see this case, we start from only 1 millimeter of residual bone. I decide to perform the sinus lift with the use of crestal drill. I decide to put only the bone in this case because we have only 1 millimeter of residual bone. So after 6 months of healing, we have the new bone in which we can insert the implant to rehabilitate for the patient rehabilitation. And this case can be understand the power of this technique, how simple, predictive, and not invasive it can be a sinus lift with a crestal approach with the CAS kit. So without this kit, we have to do a lateral approach in area 1.5, 1.6. But with use of crestal drill, I decide to perform my rehabilitation, my sinus lift, with the crestal drill. And from the first hole, I push bone, then I perform the second access in 1.6 position and push other bone. In only 10 minutes, we have the bone regeneration of the patient. So we can wait 6 months for implant insertion. This very nice treatment. The patient come in our office for implant insertion in 2.5 area, and we can help him. But after the period of healing, after the rehabilitation, he come again in our office because we want to put another implant in 2.6 area. But the problem is that the distal part of the implant that we have in the past inserted has a contact with the membrane of the patient. So the attachment with this membrane can be very challenging. So we can we decide to use the crestal approach, and with the saline solution, we detach the membrane from the distal area of the implant. And I decided to stop my surgery with the insertion of the bone. After a period of healing of 6 months, I have the new bone regenerated, and so I can put the implant in area 2.6. And this is when we finish our rehabilitation with the satisfaction of the patient. So modern literature tells us the survival of implant insert in combination with sinus floor elevation is comparable with the implant placement in non-regenerated areas. Prestal approach with automatic drill can be used to the likely referential approach for maxillary sinus treatment with residual native bone less than 5 millimeter. But as I have already shown you, I try to use this technique even when I have less than 5 millimeter, even when I have 3 or 2 millimeter. And when I have only 1 millimeter residual bone, I decide to put only the bone inside the sinus. After a period of 6 months of regeneration, I decide to insert the implant for safety. Now, I want to start speaking about the elevation of the sinus with the use of a lateral approach. And this technique was described first by Tatum in 1977, and then Boy and James published this technique in 1918. This technique is performed with the use of a drill that create an access on the lateral wall. This access can be an access wall or a trapdoor. We can decide it according to the anatomy of the sinus. And after the detachment of the membrane, that starts from the base of the sinus, then we can perform it in the distal area and then in the upper area. We have to detach the membrane in the angle between lateral wall and medial wall. That is the angle, the area in which are very frequent the tearing of the membrane. When we detach the membrane and we elevate it, we can start the insertion of the bone or the preparation of the hole for the implant positioning. And when we reach the desired height of the bone graft inside the sinus, we can put the membrane to protect everything. Here I show all the phase of the treatment, and this is the trapdoor. And when I detach the membrane, I prepare the hole for the implant. You can see the detachment of the membrane. And then we can insert the bone inside the sinus. After the insertion of the bone, we can insert two implants, cover everything with bone and protect everything with use of membrane. I prefer the stabilization of membrane using pin. The most important complication of this approach is the perforation of the membrane, but even the laceration of the arterial artery that you can see during the surgery. If we have a perforation, we have to expand the osteotomy until we can see very well the perforated area, so we can continue the elevation where the membrane is intact. The perforation can be covered and still repairing using resorbable membrane. Perforation risk with the classical lateral approach is between 14 and 56% of the cases treated with this technique. Most important causes of the perforation are the thickness of the membrane. So we have a 41% of perforation for membrane less than 1.5 millimeter thick. The second factor is the sinus depth. And the third factor is the angle between the lateral and medial wall. If we have angle exceeded the 60 degree, it's very rare to create a tearing of the membrane. But if we have an angle less than 30 degree, we have the 62% of possibility of creating tearing. We can use last drill from last kit to create a trapdoor or an access hole in few seconds. And this is how the last kit, the last drill works. So we can create an access, and then we can decide if we want to remove this access or for an access hole or create a trapdoor. When we detach the membrane, as I have already told you, I start from the base, then I go on the back area, then in the upper area, finally in the angle between lateral and medial wall. That is the area in which we can perform the most important perforation of the membrane. And then we can insert bone. After the insertion of bone, we can insert the implant. And finally, we can cover everything with use of membrane. In the videos, you can see how I try to protect the membrane during the preparation of the hole for implant insertion. And when I reach the desired higher of the area, I can insert the implant. Every step, I check every step with the use of X-ray, sometimes with little X-ray, sometimes with use of combine to see in a three-dimensional way all the part of the surgery area. Now I'm pushing the bone inside the sinus, and finally I cover everything with the membrane. Sometimes I decide to use a cascade with a simultaneous vertical GBR with use non-resorbable membrane in a case like this. So this is the residual bone of the patient. I perform my sinus elevation, and then I cover the bone that I use, the graft that I use for bone alveolar bone regeneration. I cover everything with the non-resorbable membrane. I prefer to fix the membrane with use of pins. And this is the first intention closure of the with the suture. After a period of 6 months, we have a lot of new regenerated bone that is ready to receive our implant. And the surgery in which we decide to insert our implant is very simple. It starts with the remotion of the membrane. This is the new regenerated bone that is ready for implant positioning. And this is the new blooding holes. I put 2 implants and I wait for osseointegration. Then I have to perform the correction of the soft tissue. So this is the flap that we prepare, the positioning of a healing abutment. And after this, I put a screw provisional crown, not an occlusion, to allow the maturation of the new young bone. This phase is called progressive functionalization of the new regenerated bone. And after 3 months with the provisional crown, the bone is ready to receive the final screw crowns. And this is the end of the patient rehabilitation. The use of technique, the new technique, the use of this device, and the use of digital printing and digital activity can help us to a new kind of approach. And I try to manage this rehabilitation of the patient, in which we can see that we have vertical loss of bone and pneumatization of the sinus in only 30 minutes. In this case, I use a crestal approach with a cascade for bone regeneration, and at the same time, I use a device customized, customized mesh that helped me to perform a vertical bone regeneration simultaneous with the crestal approach in only 30 minutes. So we can be very less invasive than in the past, and our surgery can be predictable and not invasive for the patient. Thank you for your attention, and thank you to everyone that helped to realize my work. This is a part of a wonderful team.